All right, I'll do that. Bingo.
Okay. Everybody can see the words nephropathology round?
Yes.
Yes?
I think we're good.
And I am going to make sure that this is presentation mode. Oh, okay, that's fine. So the very first piece, we put out 3 panels. And so if somebody from OSU, i.e. Becca, wants to start, because Becca is the one that's here right now. George, you have downloaded the Dropbox images.
Yes.
The images from Dropbox. If you could pull up the first case, and we'll see if Becca can do a basic description. And Becca, I'm just going to hand you my phone.
Well, if that's the case, then we're going to have we'll have to have me be the presenter back.
That's fine.
All right. I think this is, you should be able to see the H&E panel for the first case.
Correct.
Is that correct?
Yes.
All right. Whoever's talking about it, if you want, you just tell me to move to whichever panel, and I'll get us there. And if you want, I can give you mouse and keyboard control, or I can just follow along. And oh, I know what we forgot to do last time is make a good thing for how. Is this an easier thing to see for pointing to things than the little hand or arrow?
That works.
Because the other one is to do it this way. That's a hand. Let's see. Ah, this is maybe even better. Is that too small? Can you see?
No,
all right.
I think the red is probably
the red is the best? All right. We'll do that. Okay. So I'll leave it over here for the time being. Fire away.
All right. Well, this is Becca Conkin. I'm the first-year resident at Ohio State, and I'm the only one here. So I'm doing this first panel. I'm the only anatomic here. So looking at this glomerulus, I think that the mesangium is multifocally expanded, and I think that there's too many mesangial cells or proliferation of mesangial cells multifocally throughout the glomerular tuft. I think there's some hypertrophy of parietal cells in Bowman's capsule, and there might be some syncytiation, although it's kind of hard to tell, on H&E. And that was pretty much it for the H&E. So we can go to...
All right. Let's see. I see what happens. No, give me just a moment to... I have to switch back and forth. Did you want to do the PAS next?
Yeah, sure. I didn't have too much to add, though.
But you're correct. And another piece of this is that it's a little easier to appreciate this is and this are and to a certain extent here it's at least for me, easier to appreciate that these are truly areas of mesangial expansion with increased mesangial cellularity. Okay.
Sure.
All right. No. You were right the first time. I just think that the anatomic sort of categorization of what we're looking at is a little more distinct in that regard. And let's go then to the silver stain or method. It's not truly a stain, Rachel keeps telling me. All right. And we'll get back to that.
Sure. So on the silver, I thought that I could make out some spikes. I don't remember what the more specific term for them is.
That's what we call them. And
perfect. Well,
all right. This is a capillary loop would exhibit that, and this one here would be. What do you think about just the general thickness of the GBM on the silver stain here?
I wasn't overly impressed by the thickness of the basement membrane. It might be multifocally thickened, but I had a little bit of trouble with that.
Well, let's see here. I would suggest to you that this one, and especially out here for being so peripheral, they're a bit too thick.
They're thick.
Okay?
Okay.
All right.
Yeah, I'm with you.
And this is the trichrome?
Trichrome. Mm-hmm.
Let's go back to the Jones here just for a minute. This is one of the ones where you can often see more clearly the synechia, and I think this is just touching as opposed to, but here, you know, there's really not a direct connective tissue link between the, you know, matrix of the capillary walls and the matrix of the Bowman's capsule, so that this one isn't actually illustrating them. And sometimes go into this stain is the way to sort of figure out whether they're actually connected as opposed to just being up against one another. And it's
okay, and the trichrome can help with that as well. So.
Absolutely. There you go. Okay?
Okay. Yep.
All right, and off to the EM. Let's see, that's a little too big. Let's see here. Are you good with ultrastructure?
We'll see, I suppose.
All right,
so
fire up.
We're the center of the screen is a capillary lumen. And we have two endothelial cells, and you can appreciate the basement membrane, which is kind of irregularly thickened, and then subjacent to that are kind of whorls or granular deposits of a more electron-dense material that's kind of swirling.
Right here, here. Yeah.
Yeah. Yeah.
Right.
So that's what I was interpreting as the lesion of interest.
Mm-hmm. What do you think of another piece of it? There's actually, I mean, and getting focused on the basement membrane. Finding the basement membrane in an EM is always sort of the first step, getting oriented. Yep. So capillary lumen, red blood cell, endothelial cells, epithelial cells out here. There's a little bit of discernible foot process, but mostly they're effaced here, okay, and here, and here. And out here, this is villus transformation, is it not? Okay. And off screen is probably some of that podocyte or visceral epithelial cell hypertrophy that you were commenting about before. All right.
Okay.
And the other thing is that you're correct about the irregularity of the thickness, but the irregularity is mostly on the subepithelial or abluminal surface, and is attributable to response of the GBM matrix production by the cells in the field to and in this instance, for instance, surrounding the electron-dense deposit, and here as well. Okay, so it's pretty much you get the idea that the deposits are being laid down on the outside, and then are being responded to and encompassed by the remodeled GBM. Okay. We good there?
Yeah.
Did I tell any lies, Rachel?
Nope.
All right. So, well, Rachel's the expert. I just work here. All right. So we have, she selected 2 of the immunostains, and I'll make them a little bigger so we look at them one at a time. Oops. There we go. You get them too big, they pixelate. So, all right. So this is lambda light chains, which is sort of goes along with IgG and to a certain extent IgM and things. So it just stains brighter.
Okay. Yeah, I have trouble reading IF, but I thought this was, I called it just positive. I think that the staining is highlighting the glomerular tuft pretty specifically. Yeah.
And that's true, but importantly, you get, it's not just, green. You get a sense of granularity, and it is the capillary. This one maybe is a one you get a sense of, and again, the IF is always hard to photograph well. I mean, one, it's harder to cut them thin and get them all in the focal plane, and et cetera, and sometimes it's a bit like taking a picture of the dark side of the moon if it's low intensity. But this is a capillary loop that gives you a sense of distinct granular deposits in the capillary wall. You get that sense with this one as well, okay? And then if you have that idea in your head, these are almost confluent, and you wonder whether it's the picture or, exactly how it's stained there. But you get a sense of granular fluorescence, which is consistent with the deposits we just saw. And then in places you wonder about it, extending into the mesangium, but this one is not a very, for instance here, you might say, well, there's mesangial staining as well in that area, okay?
Okay, so we're going to kind of go to the diagnosis about this because we have a lot of cases.
Yep, all right, okay.
So both the Lambda and C3 have the same type of staining process, and Becca, the best diagnosis that you could come up with was, so it's an immune complex mediated, and we often talk about different patterns of immune complex deposition, and this one had sub-epithelial electron dense deposits and was really very minimally hypercellular. There was some hypercellularity, but it was mild. And so that gives it a membranous pattern. And George, if you make me the presenter now, I have a little bit of a PowerPoint about this. I also specifically asked for 2 possible clinical findings, and these are kind of good follow-up questions, especially for boards exam situations, and everybody can see what I'm saying, right?
I can, yeah.
Okay, so hold on. And for these, anything that would be seen in the nephrotic syndrome would be an acceptable answer. Anything that would be proteinuria, ascites, hypoalbuminemia, and the key factor is not discussing the presence of azotemia, because these dogs really have very minimal tubulointerstitial disease, and that would be something you would expect to examine the tubulointerstitial compartment. We obviously just showed you photographs of the glomeruli, but the glomerulus is still patent and the capillary loops are still open. So azotemia is usually not seen, especially in these kind of cases where it's just glomerular lesion and no tubulointerstitial disease. So
and this dog fit that pattern.
Hello?
Sorry, I said this dog. Sorry, I just said that this dog fit that with a serum creatinine of 0.8, but an albumin
and
that
so
was
I have
low and
a little bit. Yeah, and I have some different things, and all of this will be sent to you guys. You guys can download it from Dropbox as well. But this was my description, with the bold kind of text being probably the most important. I often talk about looking at histology, looking at the podocyte hypertrophy, and with studying with the MDs, they often look at how those nuclei are oriented.
and if they're really oriented towards the urinary space with those nuclei almost, jumping, it looks like the podocytes are jumping ship is how they used to joke about it, because the podocytes are really uncomfortable with the fact that there are electron-dense deposits beneath them. And I know that's anthropomorphizing, but it kind of helps everybody remember what's going on. So if you see prominent podocyte hypertrophy and nuclei oriented to the urinary space, that should kind of give you a hint on histology. The spike-like projections are really important, and that gives us a really good sense that there is something, again, on the glomerular capillary wall that's stimulating production of new glomerular basement membrane. So those are key features. In this particular case, you really couldn't appreciate the immune complexes on the trichrome stain, although some cases they're quite prominent and we can see them on the trichrome stain. It just wasn't present on this particular case. Then, the EM and IS, again, Becca hit most of the important points. I think on EM you talk about electron-dense deposits, which you can interpret them as immune complexes based on their characteristics. There was one deposit that was undergoing dissolution, and it was kind of the electron-lucent area, which kind of suggests that there's been a little bit of chronicity because there is some kind of dissolution of the deposit. And then IS is perfect about, noting what stains we stain with. And then the granular is a really key word when we talk about positivity for immunofluorescence. So if it's just, bright staining or splotchy staining or blush staining or whatever, the granularity is actually indicative of immune complex disease, whereas all the other patterns can be somewhat nonspecific. And can be actually artifacts. So splotchy staining can be artifact and it can be nonspecific. So granularity is what you really want to look for.
Rachel,
anything?
Quick
Yes?
question, Rachel. On EM, I also was wondering about microvillus transformation. Would you call that?
Yeah, we see that a lot. I think I didn't put it in my description. We just see it on so many things where podocytes are injured. But that would be another thing that it's definitely there, and it's prominent in this case. So everybody saw the little kind of cytoplasmic projections on the EM picture coming off the podocyte, and we see that a lot in podocyte injury, and it could be it's a very nonspecific change. So this is for everybody to kind of read afterwards, but the take-home points is that membranous glomerulonephropathy used to be, in veterinary pathology, a thickened glomerular basement membrane. But now that we have a good biopsy, a biopsy service, oh, sorry, I'm asked to slow down, sorry, I apologize. So thank you for picking up, because I do talk very quickly. Membranous used to be a disease where histologically there was a thickened glomerular basement membrane. And now we have modified that, and it's specifically a disease that has to have immune complexes. And almost always they're located in a position between the glomerular basement membrane and the podocyte, like we saw in this case. The fact that they are on the outside of the capillary loop, they're away from the capillary lumen, it means that if they activate the complement system, they're not going to attract inflammatory cells. And that's kind of the basic difference between membranous and what we'll see later with membranoproliferative. So when they're on the outside of the capillary loop, there is very little chemotaxis or attraction of inflammatory cells because they're not in a location that can induce that response. If you aren't able to do EM or you're not able to do immunofluorescence, you should at least be able to see evidence of remodeling, which is what we saw on these silver stains. Those spikes, those spike-like projections, and so that would give you confidence that it's going to be a membranous glomerulonephropathy. If you have a smooth outer contour, then it's not likely to be membranous glomerulonephropathy. So just having a thick basement membrane no longer meets the cutoff for the diagnosis. It has to have remodeling. If I'm unsure and I have just light microscopy, I simply call it a glomerulopathy characterized by glomerular basement membrane thickening. I don't go through with membranous because to me that is an immune complex mediated disease. As Becca pointed out in her description, there is some mild mesangial hypercellularity in this particular case. We often see that in this disease. That still is okay in membranous. Remember, I think I told you last month that the mesangial cells will proliferate with very little stimulation. They just like to proliferate. That's what they do. So, so just having mesangial hypercellularity is okay. It still can be something that happens with membranous disease. And then I put in italics that it's our impression, and that's just based on what George and I see and Mary and I see at the Veterinary Renal Pathology Service, that if you have a membranous diagnosis and you have very little tubulointerstitial scarring, you probably have a reasonably good prognosis because we can, especially if you treat with immunosuppressive therapy, again, it's because there's really no scarring yet in the specimen. So though it's it is our impression at our service that it seems to have a pretty good prognosis, and that's the impression in humans as well. And then the two last points, or last 3 points, are kind of how membranous in humans, it actually gets subdivided into two separate categories, either secondary or primary/idiopathic. We think in veterinary species we often see the secondary phenomenon, but again, we haven't really looked for the protein that is involved in primary membranous, which is the phospholipase A2 receptor. And so because it hasn't been investigated in dogs, it's probably beyond what the scope of what you need to know for boards. Nobody knows it in veterinary species. And then just keep in mind that this process could possibly recur in humans, and we think sometimes it might be able to recur in dogs as well. Any questions about membranous and pathogenesis or diagnostic criteria? I know I speak quickly, so please ask questions, either type them out, and they should pop up on the side of my screen.
I think we're good.
Anyone? I think we're good. Okay. Okay, so we can go to the next case, George, which is a little difficult. Not as difficult, it's maybe not something that everybody has seen because it wasn't in the original paper I sent. Are there volunteers in the outside world that so I can put this thing on mic and speakers, and anybody from maybe Texas A&M? I know you guys were going to volunteer last month. Anyone?
I think the TAMU folks may not have a microphone.
Oh, okay.
All right.
I see.
Why not, do you want me to just give you mouse and keyboard control and let you just drive here?
Okay. Okay, since this is a little bit more of a case that wasn't really presented in the original paper, I'm happy to do this one because I don't want to scare anybody away. And again, the stains actually kind of show similar features for all of the stains, namely that we have some hypercellularity within the mesangial compartment. Up here we have probably about 20 nuclei within one segment. So it is segmental mesangial hypercellularity that is present in the PAS as well, which we can...
I'm going there.
Okay. How do you know they're mesangial? So the question here was how do I know that it's mesangial cells, and I think the PAS helps you. So the PAS really delineates where the mesangial matrix is, and you can see that there is, I think I've got, yeah, now I have the pointer. So we have too many cells here within the mesangial zone, whereas your actual capillary lumens are completely open. So that's how we know it's mesangial hypercellularity as opposed to the other term being endocapillary hypercellularity. So mesangial hypercellularity we're confident about. We do have some hypertrophy and almost like foaminess of the podocyte cytoplasm. Again, podocytes often get activated and reactive for many reasons. So both the mesangial cells and the podocyte prominence are somewhat nonspecific. In addition to the mesangial hypercellularity, you have too much mesangial matrix. The fact that I can fit, 3 of these dots in there is too much mesangial matrix. It should be very fine, delicate, and lacy. It's hard to really evaluate the glomerular basement membrane. Sometimes it looks in normal thickness. Sometimes it looks a little mildly thickened. And if we go to the silver stain, George.
Yep. I have to
Rachel,
switch back and forth with the
Yeah,
things in order to do this. And again, folks, the silver stain and the PAS are the ones that allow you to separate the different compartments within the glomerulus and begin to figure out where the changes are, mesangial, endocapillary, and that sort of thing. Do not, the fact that we look at it in the H&E and begin to spout off about where things are is sort of reading between the lines as opposed to actually being able to see it clearly.
And Rachel, would you mind just helping to delineate how you would know that that's just nitrous expansion versus sclerosis?
Oh, okay. And this was, so the question, I guess, for everybody to hear, difference between mesangial expansion versus glomerulosclerosis or segmental glomerulosclerosis. So sclerosis requires actual effacement of the peripheral capillary loop, and whereas mesangial expansion is just, it's just obviously expansion of those zones, but the capillary loops themselves have not been effaced by extracellular matrix. So once the capillary
so this, for instance, out here, this is the changes just in the mesangium. It has not solidified this entire lobule or this one, right. Or that's the point, I think, right?
Yeah. And so, okay, so the silver stain, again, it is a little, there is some variability about thickness of the glomerular basement membrane. In most areas, the basement membrane has a smooth outer contour. There are some hints of some irregularities on some capillary loops, but in most capillary loops, it's a smooth outer contour. And I think the trichrome is very much similar to what we were looking at before. Yeah, it is. There are some areas. So the question here at OSU is are they thick? And again, there are some capillary loops that appear thickened or that are mildly thickened, and then there are other capillary loops, like this one is of normal thickness. So it is irregularly thickened, but again, having a smooth outer contour is important. And we see the same thing on the trichrome stain as well. Oh, is there a question at the 9 o'clock position, and you're asking about on the silver stain or on the trichrome and silver? So, and I think we kind of highlighted, or we talked about it earlier. The silver stain is probably a really good way to assess for synechia. Here we have the vascular pole, and so whether or not this is just sitting very closely, I often, if it's this equivocal, sorry, and I realize that the question was sent to me, and maybe not everybody can see it, but the question is this right here a synechia? And if it's this equivocal, Jeremy, I usually like to see some kind of reaction around the outside. So I like to see multi-lamination of the glomerular, or sorry, of Bowman's capsule basement membrane, or maybe a little bit of fibrosis right out here. So, if it just looks like it's one tiny little pinpoint area that's touching, I probably would ignore it. That's not to say that there's probably synechia elsewhere in this specimen. So,
you actually might actually be more fretful about this particular spot here than out here, but again, you will want to see it with more evidence that it really matters than to just because it's opposed. Yeah.
Right. Okay, so we can do the EM right now, George, I guess. Okay, so again, we have a single capillary loop. We have the endothelial cell nucleus at the base of the capillary loop, kind of resting on the mesangium, and that's exactly where it should be.
You can drive now.
And the capillary itself has, extending from the mesangium out into the actual wall of the capillary loop are variably electron-dense deposits. They're quite large, and they are going in between the endothelial cell cytoplasm here and glomerular basement membrane here. So they are quite prominent in the mesangial zones, and then they have a continuous extension out into the capillary wall. Here, everybody can see the foot process effacement. Everybody can see these little cytoplasmic projections, which is the microvillus transformation. Again, a somewhat non-specific change. And then the endothelial cell cytoplasm really isn't reacting, or it's fairly normal, and the endothelial cell nucleus is in a normal location. If we go to the immunofluorescence, we can verify that electron-dense material are in fact immune complexes, and that's because they are staining positive with lambda light chain. And if we kind of, and I think if you guys go back and compare what we see on the lambda light chain and the C3 for this case versus the previous case, these are a lot chunkier. There is a little bit of granularity out here, but these are a lot chunkier, and we're also, and this just takes experience, but this is highlighting mesangial zones, whereas a lot of the capillary loops that are out here are not staining. So what we saw in the EM being very mesangial based and kind of going out to the neck of the capillary loop is being reflected in our immunofluorescence. And so the diagnosis for this case is actually mesangioproliferative glomerulonephritis, and the C3 mirrors that as well. Maybe a little bit more capillary loop staining on the C3 than on the lambda light chain, but they're both there. And so now, if I am the presenter, George.
I'm getting you.
Yeah, I know, that's
working
fine.
on it.
Oh, and so I did forget to do my next slide for membranous, but you guys will actually, that you will have the actual history for, this is the history for the case with membranous, so that you'll have a little more clinical data for that particular case. But like we said, this patient was not azotemic, and that was the membranous case. So for the next slide, if I can get it to go. Case 2, I did the description, I gave the diagnosis. Again, you'll have all of the description that I assumed was or predicted to be the most important points. And it is a mesangioproliferative glomerulonephropathy, also called mesangioproliferative glomerulonephritis. And the reason I put question marks is because it's a fairly not really well understood disease in animals. It is actually one of the most common, I guess I shouldn't say cause of proteinuria, I guess I should say one of the most common glomerulonephritis in humans. So I will change that before you guys all have access to this PowerPoint. But it is one of the most common diagnoses we get from humans with renal biopsy. And that's because humans have a very high proportion of an IgA glomerulonephritis. And it is restricted or it's found predominantly in the Asian population. And the reason we probably don't see it as commonly in animals is that non-primates, as in everything else that's not a primate, doesn't seem to make that same IgA isoform. So IgA type 1 is the isoform that is involved in mesangioproliferative glomerulonephritis. And because anything that's not a primate can't make IgA type 1, we probably just don't see the disease the way we see it in humans. And we actually have seen it in some marmosets as well. so that being said, this case had IgG positive staining. I didn't show you that picture, but there is IgG positive staining in this case. And so IgG dominant proliferative disease can happen in humans, and that's probably what we see in small animals as well. So again, it seems to be fairly rare, but the reason I wanted to show it to you is because it is a fairly classic lesion. So it's one of those, you know, rare but kind of pathognomonic. You're going to see mesangial cell proliferation, you're going to see mesangial expansion, and you're going to see the EM where those complexes are starting out in the mesangium and they might be kind of infiltrating the capillary loop, but it's very prominent in the mesangial zones. And then again, the italics being that we get the clinical impression on our service, and again, we don't see this very often, but we do get the impression that it actually probably progresses to a sclerosing phenotype where you will start to have segmental sclerosis. And so if you didn't have immunofluorescence and you didn't have EM, and all you're looking at light microscopy, you could confuse this with a sclerosing, focal segmental glomerulosclerosis, which is one of the cases we looked at last month. So that kind of highlights the need for EM and immunofluorescence to kind of verify that there are actually deposits in there that's mediating this process. And this particular case was a greyhound, Italian greyhound. She was proteinuric, her UPC was 16.2, and it was identified, she wasn't clinical for it, but it was identified because they were doing an anesthetic workup because they were going to remove multiple mast cell tumors. She was not azotemic. She had a normal serum cholesterol and a normal, and she was not hypertensive. And when they did the anesthesia for the mast cell tumor removals, they went ahead and got some biopsies at the same time, and this is what we found. Again, not very common in our service, but the histopathology and the electron microscopy and the immunofluorescence are classic, and that's kind of when I want to show it to everybody. Okay? Any questions about mesangial proliferative disease? Anyone? Any type of circulating So to that question here is pathogenesis. Is this a similar pathogenesis? Do you have a circulating immune complex? Do you have circulating immune complexes? And we actually don't know. We do know. So I can only speak to what we know in humans, and that's because they make a poorly glycosylated IgA, so that they start to bind antibodies to their IgA. We don't have any clue in dogs. So whether or not these are circulating immune complexes that then just get, pushed into the mesangium, or whether you're actually making antibodies against mesangial proteins, it's really hard to say. I do think these are often kind of a chunky deposit as opposed to really good granularity. So again, we just don't have enough data right now to know what happens or how the pathogenesis in dogs.
We have a very small set of these cases, period, in dogs, and nobody has gotten beyond just recognizing that they exist in terms of figuring out issues about pathogenesis or implications for pathogenesis.
Okay. So we have one last panel, which I think is pretty, again, straightforward. So we could do the panel. And again, actually nobody has microphones, so everybody's basically calling in on a phone. Is that correct? Somebody want to pick the phone and...
I'm not sure we have anyone but the volunteers need to step forward right away, or let Rachel go. We'll leave it up to you.
I would prefer if somebody would step forward, because this is...
Rachel, I'm here, but I spoke last month.
Hey, Shannon will help. Okay, so we're...
Fire away. Who needs a pointer? Is it Shannon?
Yeah, but you know what, George? I'm fine with just saying, using the clock, or you can point for me. So
okay.
I don't know.
All right.
And again, I apologize. I didn't prep beforehand, so...
we'll forgive you.
Thank you. Okay, so we're looking at single glomerulus, and I think the prominent feature here is the marked proliferation of mesangial cells. And other than that, on this H&E, I think that's probably about it. You can basically see that diffusely the glomerulus is affected by numerous cells.
I'd point out two things further. One is the sense of lobulation here.
Okay, yeah.
Okay, all right, that's something that shows up in this disease. And the other thing, although we'll see it more with other, is that the cellularity, which is greatly mesangial, there's also a paucity of patent capillary lumens in these, right?
Yep.
Okay.
Great, thank you.
Here's the PAS.
Okay, so I think that kind of the same features here. I think that the capillary loops are a little bit more evident in the stain, as you said. And then as far as thickness of the GBM, I would say peripherally, like at 3 o'clock, they look okay. But I would say in other regions, multifocally, like at 6 o'clock, I think that there is thickening of the GBM potentially in some areas, but otherwise they look all right. So the silver, again, peripherally at like 3 o'clock they look okay, but internally I'm almost seeing some, I don't know if there's some double contours or some...
Might be a little bit right here.
Yeah,
Okay.
yeah, and then kind of down from where your arrow was just at, it almost looks like there's a little bit of loopholes, kind of right at the center, but yeah.
Well, yeah, but that's sort of out in mesangial areas. You'll want to look for double contours out in the peripheral capillary loops. But another point here is that now one can begin to have a sense of cellularity within the lumens of capillaries. So this is not just that you get more of a sense of endocapillary hypercellularity, because now you can tell where the basement membranes are, where the lumens are, in a much better sort of appreciation of anatomical separation of different compartments within the glomerulus with this stain versus even this one, and certainly with regard to this one. So this is a stain where, although they're not all obliterated by the cellularity, a great amount of the hypercellularity is actually within the lumen of the capillaries. All right?
Okay, great. So for the trichrome, it's kind of the same deal. You have the hypercellularity. You're still able to see some of the capillary loops.
Yeah, more of the same.
Yeah.
Okay, all right.
Okay, so for the EM, obviously directly in the center is going to be the capillary lumen, and then you can, on the periphery, you can see the GBM.
Yep.
And at that area right there,
Okay.
George,
Right.
is those electron dense, is that just part of the endothelium? Because it kind of seems like it's not really incorporated into the GBM.
Well, the point of this is that there are, number one, electron-dense deposits in the capillary wall. All right? And in contrast to the first one we looked at, they are all located on the luminal side of the original GBM rather than on the abluminal side. Okay.
Yeah, and then there's foot process effacement.
And foot process effacement and a variety of other things. Although the microvillus transformation, at least in this field, is not as prominent. There's a couple of them. But the key point now here, you can actually, I mean, if it was truly pure subendothelial, what would be over the basement membrane would be nothing except endothelial cytoplasm. But we have a little, this is some reactive change and whatnot. Now that there's an endothelial cell out here pretty much out in the periphery, or maybe even a mesangial cell. You can't tell them apart by EM per se, but there is some cellular interpositioning in the capillary wall and whatnot. But but this is about as close to a pure subendothelial deposit. Now, they're all in the place where they need to be for, again, Rachel made the point before, when the immune deposits are on this side, the immune amplification system it turns on all the complement and recruitment of inflammatory cells and cytokines and everything that make such an endocapillary cellular reactivity and recruit inflammatory cells. All that's happening because these are on a side where the bloodstream is bringing all those materials for inflammation to it. And so,
yep.
All right?
And so we have, you're right, we have electron dense deposits, and I think even here,
oops,
right below that endothelial cell nucleus, there's some new basement membrane formation. So
right.
Remember the endothelial cell and the podocyte synthesize the glomerular basement membrane. So the presence of deposits stimulates new synthesis of new glomerular basement membrane by that endothelial cell. So that gives us our double contours when we are looking on histopathology. It's the fact that the endothelial cell is synthesizing new glomerular basement membrane to separate itself from those underlying immune complexes. And again, the immunofluorescence verifies that the electron dense deposits we saw are in fact immune complexes, again with the lambda light chain and the C3. And in the interest of time, we're going to head to the PowerPoint, George.
All right. The other, okay.
Yeah,
I'm getting, well, there's some nuclear debris and things there that we would focus on some other day.
So, great job, Shannon. Thank you for stepping up. And again, next time when we do this, everyone will have our
okay. You're good.
Microphones, and we will have our own microphone, I promise, because we ordered one for this particular room. We were trying to use a broken one today. So this is from a dog. Again, we gave the description, very hypercellular. We have immune complexes, and they're in a subendothelial location. So, Shannon, your diagnosis was?
Blah. I would have said, no, I'm here. I muted you for a second. So would this be, I'm sorry, I just had a brain fart.
MPGN.
Yes.
Yeah.
Membranoproliferative.
Membranoproliferative. So the proliferation because of the hypercellularity, and then the membrano because the glomerular basement membrane is remodeled. We see this, and I asked for a possible underlying systemic disease. So anything, we often associate with Lyme disease, leishmania. It's been associated in the literature with diarrhea, and that's my description. Those are my EM and immunofluorescence descriptions, which again will be available. I even gave it points because I used this as an exam question, as a mock exam question once. This is the same disease, just for all of you guys that are trying to think about other ways we call this. It's also called mesangiocapillary glomerulonephritis. That's kind of an archaic name. We don't use it anymore, but if you come across that in the literature, it's talking about membranoproliferative. And again, a lot of diseases that we have associated with it, it's been, most of these are at least in the literature. Actually, these top 4 are in the literature, and the bottom 3 are ones that we've identified, or at least have seen cases of in the veterinary renal pathology service. And again, diagnostic criteria requires subendothelial, and then the intramembranous immune complexes can be either just hanging out in the lamina densa, or sometimes we actually call them intramembranous because because the endothelial cells are making new glomerular basement membrane. So after ages and ages of remodeling, they actually seem to be in the membrane itself. So it's just because of that kind of chronic remodeling process. But again, we assume that even the ones that have double contours at some point we're in a subendothelial location. And then again, you have to have hypercellularity. The case we saw today had, pretty good evidence of endocapillary hypercellularity. Sometimes if it's chronic, we might only see mesangial hypercellularity. So it honestly depends on the time point at which you do the biopsy. If you don't have EM or immunofluorescence, you at least need to demonstrate the double contours. Hopefully with the silver stain, you might be able to see it on a PAS stain, but that's what you need in order to diagnose it on histopath alone. And if you don't have that evidence, then again, play it safe and say glomerulopathy characterized by, for hypercellularity and irregular GVM. So I would rather people play it safe than to overdiagnose this disease. And then I kind of make a comment, and I want to spend the last 2 minutes about this concept of a pattern versus a disease. Nephropathology is probably taking the same route that dermatopathology has done in the past, where we talk about patterns of disease. So, and usually that's a histologic pattern. So having hypercellularity, having some thickened glomerular basement membranes can actually be seen in a couple of diseases that are not mediated by immune complex deposition. And in humans, it's very important to discern between the ones that are not immune complex disease and the ones that are, because you treat them completely differently. And even though we rarely see the non-immune complex ones in veterinary medicine, they're very rare in small animals, we do see them. So, so that's why having the EM and having the immunofluorescence to verify that it is immune complex mediated is really important for the clinician, because now they know they need to immunosuppress. So again, that might be some, and that is addressed in the hopefully soon to be published Jubb and Kennedy chapter, and Dr. Moore and I definitely addressed that topic of the difference between a pattern and having membranoproliferative glomerulonephritis. So if you guys have questions about that, again, that would be in the future as opposed to actually having to know it from 2014 boards. So if you're taking boards this September, then just forget everything I just said.
But going forward, the idea of pattern of injury, having and particular patterns of injury being recognizable, especially at the light microscopic level, having different disease entities that are their fundamental causes is an important concept to get ingrained into people. That calling it an MPGN pattern of injury does not mean that it's necessarily a membranoproliferative glomerulonephritis with subendothelial immune complex deposits.
So, and as an example, if I see something and I'm not 100% sure, it looks hypercellular, it looks like there could be a few foci that are remodeled, I will put on my interpretation, it has this pattern, but I need to wait for immunofluorescence and electron microscopy before I can make a definitive diagnosis. So I'm very upfront with the clinicians that submit the biopsy by saying, look, it has a pattern, but I need the additional studies before I can definitively call it. And I think there's nothing wrong with you guys doing that, especially if you're out in practice and you're reading for IDEX and you have an impression that this is what it is, but you don't want to, because you're exposing the dog to potentially very expensive and sometimes dangerous immunosuppressive therapy. So that's kind of why we're trying to at least be a little more straightforward with we do know it or we don't know it. And then again, it's our impression at the IVRPS that they're more likely to be hypertensive than other kinds of proteinuric kidney disease. This particular patient was Lyme positive. She has the random history of previously eating grapes 1 month prior, which ends up probably not being related to why she presented again. But you always have to, take that into account that there was some history of eating grapes previously. And her UPC was 4.8, but it had been around 10 1 week prior to biopsy, and she had been hypertensive 1 week prior to biopsy. I think we're out of time at this point. Does anybody have any very specific questions about the immune complex diseases that were presented today? Okay, not seeing any questions. If you have any questions, you need to email me. That would be great. And like I said, we will meet again. I think George has selected the date. I think it will be the 21st, correct, George?
If that suits you, that would be the better one for me.
Okay, so we'll send out an invitation, and like I said, we will get the conference call system working here as well so that we don't have to call from my iPhone in the future. But I'm glad that, I mean, thank you guys for at least volunteering and for speaking up. Hopefully any questions you guys have that you want to email me directly, I can respond to. And all of this will be available as a PDF probably by the end of the day, so you guys can have access to this PowerPoint. Okay?
And as before, we're all in the early phases of getting good at doing this, so feedback about what worked, what didn't work, send it to me, send it to Rachel. We're anxious to have it be effective for everyone, and letting us know what we need to improve is crucial.
Okay.
All right.
Thank you, guys. Thanks, George.
You're welcome.
Thank you. Thanks, Rachel.